This is going to be an interactive conversation. I'm going to have you think. I'm going to have you solve problems. We're going to figure things out. We're going to apply a bunch of stuff. I think it's going to be really fun, and we're going to do it together. So the running theme in this clinical approach and what Tanya sort of introduced for us is this idea of using different theories and empirical research to guide your intervention. And I actually get a huge kick out of coming to these conferences because you get the experts in a particular field that teach you about their thing. But many of you are clinicians. I was here for the clickers. So many of you are clinicians. I can see you want to apply that. But do you drink their Kool-Aid, right? Do you drink their Kool-Aid? So PRT was very interesting, but does it work for every kid in every situation? And I'm going to add one other thing to that. Does it work for every kid in every situation, for every domain? Okay, so Tanya talked to you about joint attention and how we can apply different approaches to joint attention. That's just one little tiny domain, right? So I'm going to talk a little bit about behavior today, and we're gonna try and put all of this together. And I think we're going to energize ourselves, all right? So the goal of this talk is to first think about the most important thing, I think, is for you to begin to shape your thinking. The first thing you want to do when you are faced with, and now I'm going to say behavior, but honestly, this can apply to everything. It can apply to speech, it can apply to learning skills, it can apply to joint attention. Why are the children behaving as they do? Okay, why are they doing what they do? And given that knowledge, how does one intervene? All right, so we're going to figure that out. All right, so here's our first interactive. All right, so look at this word hyperactivity. All right, why is a child hyperactive? Hi, everybody. Say hi, Stephanie. Get your mouths moving. There's no right answer. And we're going to remember all these. And if somebody would actually jot them down, thank you. Why is a child hyperactive? Just give me one. They have too much energy. Okay. Why else could a child be hyperactive? Excellent. Remember that. Hold on to those, okay? Why else? I'm going to come back to them.
Well, physically, I think a lot of they internally don't get enough stimulation.
Okay, there's an internal need for stimulation. Fabulous. Why else?
Reaction to diet.
Excellent. Reaction to diet. I gave my kid too much sugar. That's why they're hyperactive today, right? Or other reasons. Yeah. Food sensitivities. These are excellent. What else? Come on. In the environment. Perfect. What else? Lack of sleep. Excellent.
They're bored.
They're bored. Excellent. Okay. I'm sorry? Visual challenges. Perfect. Okay, you guys spent the entire afternoon in a medical model. Okay, shame on you. What else could they be?
ADHD.
Oh, there we go. Leave it to the doctor. Okay, so another reason, right? All right, so you've got all of these possibilities. Right? There's really, the really difficult thing for us interventionists is that there's actually no definitive answer. It's elusive, it's unclear. Great. For those of us that are practicing with these kids and our parents, it's like, okay, thanks a lot. That guides me into nowhere, right? But I think that after this, you're going to be able to use these theories and these explanations of children's behavior. You're going to be able to think about them in an organized way. You're going to be able to test your explanations, tailor your interventions, and we're going to go from simple to complex, and you're going to apply them systematically. And I think that you'll be able to find that all of the pieces of information that you've been getting throughout your existence as a professional, you'll organize them and be able to think about them a little better. So there we go. So paradigm paralysis, it's a deadly disease. Stay clear of it. Okay, I actually stole this, and you're going to love this. I stole this from this author named Mag, who is actually a behavior and a BCBA type guy, and he wrote this great chapter on paradigm paralysis about it's the condition characterized by an inability to see alternative points of view. He talked about don't be so consumed that you're incapable of coming up with alternate explanations. And no joke, you guys, on page 8, he said, hyperactivity, you cannot think of it as internal to the child. It doesn't come from inside the child. And I'm thinking, wait, you just taught me to think outside the box. Like, how can you then tell me that that's not one possibility? That it could be internal to the child, right? It could be a disorder characteristic of that particular child, okay? It's so easy. What I'm saying to you is the man wrote a chapter on it, and yet he fell into the same paradigm paralysis that many people easily fall into, okay? So here's what we're going to do. We're going to because the other disadvantage of being last is I've been whispered that I have literally 15 minutes. So I'm going to do this hopefully clearly and efficiently, but I have to move through it a little quickly. So I'm going to talk briefly about different general and sort of major models to approaching explanations to behavior. All right? And I'm going to group them in two things. Now, for those OTs in here, I am a big fan of sensory models, but I'm not going to go through all. I just don't have time. So I'm talking about sort of the major ways to think, and you can add and take away from these models based upon your own experiences, right, and what your own training is. But there's different kinds of models that explain behavior. The first are the type that are internal to the child, right? So you have, medical biophysical models, and that was, I thought, amazing. This afternoon was, I wanted to like take everything they say and I wanted to run up and go, and that relates to my talk here. Because they did such a great job of talking about how medical models influence the possibilities of treatments, right? You heard them touch on that each time everybody talked. We heard about molecular and clinical genetics, neurotransmitters, connectivity, right? Those are some reasons why a child might behave in the way that they do, right? They aren't making the neural connections that they need. Their genetics bring them to that particular phenotypic behavior, right? There's lots of those types of models. The other one that I have to bring up, and this is a very blatant attempt to throw my name in one of the slides here, but the other concept is the concept of psychiatric illness too, is that many, and for those of you who work with especially older children with autism, there's a lot of comorbidity, excuse the word, with psychiatric disorders like anxiety disorder, again, coming from sort of a medical model. And we did run a study to show that quite a bit of our children with ASD had co-occurring emotional behavior disorders, and these symptoms were present after 5 years. So these are things you have to take into account, right? Okay, so internal to the child. My other ones I wanted to throw in psychodynamic models. I mean, there's a lot of question about that Freudian concept of conflict within that period. Are you guys familiar with psycho? I love that everybody's shaking their head. You guys make me so happy. Keep shaking. Okay. I mean, I'll give you an example later on, but you could think about like kids going through their oral anal stages and control issues could be a psychodynamic theory. It could be coming from that idea. That is an internal model. The other one that Tanya talked about quite a bit was the developmental sort of organismic developmental approach. It's when children are reorganizing because of their own development, how they learn. And so behavior comes from this basis of a developmental pathway. They construct or create their representations. They have, and the one thing I wanted to point out also is when we talk about autism, and I use this example a lot in my clinical experience, is that, we have this tree of development. When Tanya's talked about what the typical joint attention pathway looks like, and then we have autism, right, that's developing very differently. And so we have to keep that in mind when we're thinking about these guys, is that there is a typical tree trunk of development, and then we have to watch how the children with autism develop differently. So we have to take that into account when we're thinking about applying intervention. All right? So what else? If there's internal models, there's also external models. You guys are my hero. All right, so behavioral models. And again, I'm not going to spend a whole bunch of time on this, but essentially we have to look at behavioral models as being external to the child. So environmental conditions, like conditions the child to behave in a particular way. We all know about Skinner and Pavlov. The concept is simply that the human being is a non-thinking being, and it's controlled, that being is controlled by their environment, right? Okay. Another clear one is the social learning theories. And interesting, I really like this phrase, is the no trial learning. So social learning theory is this concept that they observe and learn from their environment. They don't actually practice it, they may show it later on, okay? But they've learned that from their environment. Okay, so most of you are giving me the thumbs up like that you know these models, so I'm not going too quickly here, but I think we're on the right track. And then Dr. Wood, sorry I call people by their first names, but Dr. Wood talked about CBT. That's also a model that's external, okay? The difference is it's this, remember he talked about, it's not really the situation that controls, it's how the child perceives or thinks about or recalls that situation, okay? So think about that too when you're thinking about behavior. And then finally, these ecological sociological models, meaning the environment is the judge of whether or not that behavior is appropriate or inappropriate. Okay? So here we go. We're going to practice this once more. You have your slides, right? So go back to the first slide with the what did I do first? Internal, right? Now, given, some of you already said it, and you can fit what you've already said into it. But let's take hyperactivity again. The first model is the, what was it, the medical model, right? So which Y fits for, what am I trying to say? Help me out here. Which Y fits the medical model of hyperactivity? What would be the extension? ADHD. Bingo. Next one. What's the next one? What was the next one? Come on, guys. All right, so give me the Y for that one. Psychodynamic, hyperactivity. Come on, you psychodynamic people, you can do it. Maybe there was a conflict in their, they had difficulty pooping when they were a kid, right? They had serious bowel retainment. No, I mean, some people are shaking their heads because they're like, yes, this is a possibility. And they wouldn't let go of their bowels. And so because of that, they're constantly hyper. And they've learned that behavior over the past 3 or 4 years. Hey, hang on, all right? What's after that? Developmental. Tell me about developmental. You didn't quite mention this one. Perfect, nervous system. Also, what if I said hyperactivity in a 2-year-old? Right? Right. So, yeah, we have to apply these. We have to think about these. All right, next one, external to the child, right? So tell me about hyperactivity from an external behavioral standpoint. What would Skinner have said?
It's been shaped by the environment.
Beautiful. Or he gets majorly rewarded. I'm just going to read it. Beautiful. But yes, he got rewarded for being overactive, and so now he continues to be overactive, right? Okay, how about the social learning? His brother is, oh no.
Idolizes the Flash.
Right, exactly. And so he runs around and acts like the Flash, exactly. Or the brother is overactive, okay? Are you with me? Is this fun? Yeah, application. Okay, the last one, or the last two, cognitive behavioral. Okay, this you can do this.
It's good to be overactive.
It could, sure, and memories of it. So here's an example. Is it maybe, I was thinking about this when Dr. Wood was talking, because I really was hoping you guys would answer this and I wouldn't have to. But so you're right, but there's a memory, maybe a memory of a certain situation that then triggers hyperactivity, and that cognitive process then is linked in a way, and it's the way they perceive the situation. I'm not exactly sure, but you see, I'm just trying to make this link, okay? So, but you can think about this, but you see, I've got you thinking. You're all trying to match it. I see it. All the eyes are going to the right, left side of your brain, and you're matching it. Okay, the last one, a number of people talked about this, the ecological, sociological. A few of you mentioned this one for hyperactivity. Well, that would be a medical model, right? Because it comes from, right. Somebody mentioned it.
In a classroom, hyperactivity is undesirable, but on the playground or playing a soccer game, it is highly desirable.
Right, and there are certainly different cultures also that appreciate hyperactive boys. Really, and they are perfectly fine with that. And so put them in a classroom and they might be hyperactive, but they aren't hyperactive in the home, right? So lots of different ways to think about that. All right, you guys are perfect. All right, here we go. So as I said, there are a lot of minor theories of learning. I'm not going to go over those, but what's a sensory integration? Somebody already mentioned it when we spoke up, but there's like lots. So you can think of a sensory approach. I'm sorry?
Self-regulation.
Right, self-regulation, right, all beautiful. So we're going from there. All right, so I just thought this slide was so pretty, and I love Sarah and Stephanny, so I put it in again. But I wanted you to take a look at this and just not, and because she's here and she won't yell at me that I'm going to like say something about her here. But look, it says right there, plus associated medical features. Okay, let me just point out one of these, sleep disturbance. Could it always be a medical, and I know she didn't assume that, or neither did Dr. Spence, but is sleep disturbance always a medical feature per se? No. Should I start applying that one too? No, you can do it, right? You can go down all those internal and external models and determine where that sleep disturbance come from. It could very well be a medical model, but it could also be very external, could be Freudian, right? Maybe they slept with their parents. I'm really trying to get this Freudian thing in. You can see I'm not a Freudian, right? I'm gonna get it in there, okay? So the next set of slides is really just, and if I had more time, we would sort of go through and pick, but I want you just to take a look at them. I mean, these are the common behaviors in autism. And I didn't include things like intellectual skills or things like that. I was referring mainly to the acts of behavior, like behavior problems, behavior issues, right? So, I mean, we have communication, meaning they can't communicate, so behavior becomes the result. Social and play skills are impaired. That's a behavioral skill. Lack of motivation, restricted range of interest. I mean, you know these. So I'm like I said, this is my way of skimming through some things. How does one intervene? Now, so we've now conceptualized our why, right? Now it's time to start thinking outside the box. And as I said to you, I just think going to conferences and getting bits of information from really, really knowledgeable experts helps me be a better clinician, because as Tanya said, we have this expression that she and I made up. It's called informed eclectic. So when they say, what approach do you come from? We say informed eclectic. Feel free to use it, okay, and just mention us nicely. And what we're saying is that because we have such a range, as I said to you when I first started, not only, you know, and Shefali, you took it out of your slide, you had a one child with autism, one child with autism, right? So we have all of those children, plus we have all of the domains. So a child might learn with one style better for a skill, like color matching, but they might learn a behavioral skill in a much different fashion, depending on where they come from. So even within one child, we have domain problems of what intervention works the best. And if you heard Dr. McCracken talk about the new AEC program and how they're going to try to match interventions to the child, I mean, I love that beginning, but that's just a beginning, right? Because you match the intervention to the child, that's for their skill. But that may not necessarily work for their behavior. And there's nobody in any of those labs that will disagree that sometimes they get a kid who learns really well, but they can't control their behavior at all with the methodology that they're using to teach the skill, right? So I want you to become informed eclectic. So that's what, you know, point one is that they're individuals in all different domains. And you should also not lose sight of that long-term goal, you know, which is to improve their overall outcome. And again, don't get paradigm paralysis, right? Don't get stuck in a paradigm that doesn't work for a particular skill. Okay? The other, you know, one of the other questions that we consistently get is, well, isn't there any research that compares different approaches? And the answer to that is a resounding no. You know, there isn't a particular, now you saw PRT talk a little bit about their comparison. Remember, he did a straight ABA to a straight PRT comparison, but it was, if you noticed, it was on very specific skills, right? So can you approach that as a whole? I think it's an impossible task. You know, you just can't do that. So because of these, you have different independent variables, different outcome variables, you have difficult with fidelity, and what's not good for one is not good for all. And as we've constantly said, there are aptitude by treatment interactions. Different skills, different developmental stages means different outcomes for each kid. So we have to think theoretically and apply systematically. We have very limited data. The research doesn't tell us that. So it's up to you to figure this out. You have to walk out of here and be able to do this yourself, because you can only take bits of information and use them. You can never find it all in one package. All right, so let's do some more. I wanted to mention this one little boy because we were thinking, it just came up in my head when we were talking about eating and bowel movements. We actually had a little boy in our program who had about a 155 IQ. He was clearly had autism, but he had good social communication, and he was a very strong thinker. He was a great kid, and he refused to eat, and he didn't poop. And it was one of those things where it was absolutely horrendous. Like the going to the bathroom was, you know, all out battle, and he was a very large kid, and he was eating hardly bits of anything, okay? So tell me, just again, sort of think about the approach. Like, given his IQ, I'm just giving you that basic bit of information. Do you think that an external behavioral model, like an ABA approach, might work for a kid like that? No, it doesn't. And let me tell you, they tried. You know, they were eat this, get that, sit down, have this, go to the potty, use your iPad. I mean, they had every like reward system set up, token system set up, and they were doing this for years. Okay, you know, they tried, do you think that a kid who has a high IQ but who has autism is going to also respond to like a social modeling type, and right? I mean, people are laughing, but again, the interventionists that work with him were consistently like using models of peers in his classroom to like go to the bathroom. Do you think he like had any interest in that? And actually, he was so bright, he was very egocentric. So he was like, I really don't care what anybody else does. Like, I know what I'm doing. I'm perfectly fine with this. So what model do you think worked for this situation? Like, where do you think that we began to think about this? Now, we could go Freudian because he was holding his poop. So I keep throwing in that Freudian stuff. So what model do you think might work for him? Already, yes, brilliant, because he's cognitive. And we actually gave him back, and we actually threw in a little of the Freudian. We gave him back the control. Like, clearly this is a control issue, something didn't resolve, right? And you have a brain, and we can do like some sort of CBT stuff. And that was what worked. And I have to say that, you know, I get emails from his mom every other day going, he pooped, thank you. You know, and it's a great email, because it just says, he pooped. Exclamation point, you know, and it's this really, it was a very interesting pathway. He was 5.5 years old, you know, so we're talking 3 years of these battles with him over pooping, because the theoretical model that people were using was completely inappropriate for the behavior and the child, okay? Oh yes, we asked him. And we said, why do you poop? He said, why won't you eat? Because you're making me. Oh, okay, we won't make you anymore. Sorry, right? And we finally, and that's my joke in the clinic. My staff always laughs at me because they come in and they're like, da da da. I'm like, did you ask him? You know, these kids with pretty high IQs, did you ask him? Oh yeah. Why are you doing this? And sometimes they just tell you, and it's like, okay, now I know why you're doing this, right? It's much more difficult with kids that are nonverbal, but you can also, again, take that into account. But that is exactly what he said to us. He said, because you're making me. It became a control game. And then we did some CBT, we let go of control, and boom, he's doing just fine, okay? All right, so I'm doing great here, guys. I'm hanging in. All right, so addressing behavior. Think theoretically, apply systematically. I want you to all walk out here going, think theoretically, apply systematically, right? Okay, what model do you want to use to explain your behavior? That's up to you. I mean, you now know bits and pieces of all these different models. You have to decide. Think first about what you need to do to explain the behavior. Think about the characteristics of the kid, the characteristics of the environment, the characteristics of the behavior that you're asking for, right? Okay? And then you must, sorry, I had to throw in that ABC functional analysis stuff, right? Because you have to be able to look at the behavior clearly and understand it. You can't bypass that. It doesn't matter because because we are still right now dealing with the external behavior. As much as I wish we could, you know, change connectivity, we have to look at the external behavior that way. Okay, think of the context which occurs, matching approaches, and apply systematically. One of the things with apply systematically is go easy first, right? Pick the easier one first. Don't go with the most difficult one. And I must say to you, you know, depending on who you talk to, medication can be an easy one or medication can be the hard one. Okay? So, and many people will wait many years before they try medication, and that might have actually been the easy answer, right? But in other cases, it might not be. Okay? So you don't know. So I put a case example in, although I am right on money, but maybe if you don't mind, we can try it one more time just to ensure understanding, yeah? That we'll try it one more time. So Johnny has autism and he has a behavioral aid, but he continues to hit hard and aggressively adult teachers. So I just wanted to show you a general, you know, every time he's asked to stop doing something, he turns and smacks the teacher. It's very hard, hand to the face. Afterwards, he runs away or grabs other toy. The teacher gets upset, shocked, and says, oh, shh. And the aide comes and reprimands him. He's taken aside. Sometimes he continues to play. Sometimes he does not. Sometimes people have to chase him. And I'm not, this is an exact goal from an ABA sheet that we got about one of the kids, okay? So from the behavioral model, which was being used, what did they do? I'm going to give you that one because it was from an ABA agency. So from the behavioral model, they come from this concept that what? Rewards and punishments, right? So what did they do? Yeah, if they were really bad, they probably rewarded it and he continued to do it. But no, let's assume they were good. No, so they were good and they ignored and they tried all of this and they did all the behavioral stuff. But think about other models. First of all, you know, what if he's nonverbal? Yeah. Okay, so developmental, like that would be a developmental model, like that he's actually not developmentally capable of expressing himself, and so he's chosen another alternative, which is a lovely gesture. Okay, it's almost as good, you know, no. But yeah, like he, you know, so that's the, how would you then intervene? How would you intervene? Would you reward or punish him with a token system if it's developmental and he has a language delay? No, you guys are good, you're shaking your head. No, what would you do?
Give him a way to
Perfect. Okay, do you see how shaping the way that you think shapes how you then intervene? It makes a huge difference, and each example that you face is what's going to be, is how it's going to change how you react. Okay, what if he does have overactivity, hyperactivity, that type of thing? What if he's very impulsive? He's actually a really pleasant child most of the time, but that's an impulsive act. He's maybe 10. Sure, sure. Okay, that's a behavioral way. Sure, what else? Doctors. You could give him medication, right? Again, I'm not saying that any of these are correct. I'm just saying take a look at what model you can choose and decide whether or not that applies. So have I pounded that into you enough? Did you make it through the last half hour okay? Yeah, all right. Thanks so much, you guys.